All right, I think I'll go ahead and get us started. I'm sure people will still continue to join. Um, Welcome to our annual Fall Implementation Science Seminar Series. My name is Dr. Alethea DeRosiers. I am an associate professor in the Department of Psychiatry and Human Behavior at Brown University, and I'll be hosting the Fall Seminar Series. This is now the 8th year of our Bridge program's Implementation Science Programming, and we are thrilled to bring these seminars to our Providence and Rhode Island community of implementation scientists, as well as those of you who are joining us from other regions. We are also grateful for the partnership of the Advanced Rhode Island Clinical and Translational Research, or Advanced CTR, for supporting the technology, logistics, and marketing of these seminars, and we recognize our partnership with the Brown Alcohol Research Center on HIV for their support. And now it's my pleasure to introduce our speaker for today, Dr. Noah Triplett. Dr. Triplett is an assistant professor in the Department of Behavioral and Community Health in the School of Public Health at the University of Maryland, College Park. He is also a faculty affiliate of the Global Mental Health and Addiction Program and what I hope is pronounced CSAR, the Center for Substance Use, Addiction, and Health Research. Dr. Triplett's research applies implementation science and participatory research methodologies to improve behavioral health outcomes. He studies systemic and sociological contributors to behavioral health challenges, as well as strategies to increase access to evidence-based practices for behavioral health problems. The title of his presentation today is Applying Community-Partnered and Pragmatic Implementation Research Methods to Address Adolescent Substance Use. As a reminder, you can put your questions in the chat function at the end or throughout the seminar, and we'll save time for Q&A at the end. And now I'll turn it over to you, Dr. Triplett. Thank you so much.
Thank you. All right, I'm excited to be here, everyone. And I hope that my talk, as you'll see, is more focused on implementation research methods. So I'll do a deep dive into the methods, and I hope that that serves as a good basis for us to have some discussion afterwards. And so I won't present many results, but hopefully this will get things going. And with all of that said, I hope this will be pretty informal and we can think of it more as like a workshop or things to discuss after, because I think that'll be more useful and hopefully more engaging for all of us. So to set an agenda, I'll provide a little bit of background on adolescent substance use, and then I'll move into discussing two different studies, one of which is currently underway, and then the other hopefully will be kicking off soon, and then discuss very briefly some implications for D&I research, thinking back about the methods that I've presented and also my own experiences in D&I research, and then I'll also save time for some questions at the end. So in way of background, we know that substance use remains a leading threat to adolescent health in the United States. And high-risk substance use persists despite lower prevalence in recent years. So in recent years, the prevalence of substance use, and particularly things like overdose, has decreased, but we know that high-risk substance use still persists. And increasing amounts of fentanyl in the drug supply and other drugs makes even occasional use dangerous. So even if there is a lower prevalence of substance use disorders, but still higher risk in frequent use, there's still a need to invest in intervention. Especially because earlier drug use is predictive of later opioid use disorder and other substance use disorders. So intervening early, whether that be through prevention or early intervention, is really critical for improving later outcomes. As I said, early engagement in care can reduce use and prevent later escalation to more serious problems, including opioid use disorder. At the same time that we see this rising risk of substance use disorders, we know that drug use and overdose has not impacted all US communities equally. And in particular, rural adolescents seem to be more likely than their peers in urban areas to engage in high-risk substance use, including opioid misuse. I'll focus my talk mostly on rural adolescents as being a particularly high-risk population in need of intervention, but I don't want to suggest that they are the only community that has been disproportionately impacted by drug use in the US, but rather we'll just kind of say that they are one community that has been impacted. We also know that rural adolescents face unique challenges with accessing mental health and substance use care. Of course, access to mental health and substance use care is poor really across the globe and across many communities and areas in the US. But there are specific challenges that we see often in rural communities due to challenges with transportation, longer distances to existing providers, and a sort of lower supply of providers in those areas. So all of this points to a need to develop effective and innovative models to address rural adolescent substance use. School and community partnerships may be able to address critical gaps in behavioral health care and rural settings. School-based staff and mental health teams are often at the front lines of supporting youth with behavioral health challenges. I use behavioral health here, meaning broader than just substance use. We know that school-based mental health teams are really critical in increasing access to care. And even schools that don't have mental health teams, but just have guidance counselors or teachers, they're often the first people who are aware that kids are struggling with mental health, substance use, or behavioral health challenges. And this may be particularly true in rural settings where other service providers are more limited. So, of course, every rural community is not a monolith, but in rural communities where there are less other services, there are less after-school care providers, there may be less other things to do, there are just fewer eyes on kids and fewer opportunities to identify where kids may be having behavioral health challenges. So in these settings in particular, school and community partnerships may be key in addressing critical gaps in behavioral health care. But at the same time, we know that school-based teams are often overextended and may lack the critical expertise and in particular resources needed to address substance use, particularly high-risk substance use like early opioid misuse. One potential strategies to address this challenge is developing partnerships between rural schools and local substance use care providers. These local providers may help schools close critical gaps for adolescent substance use. However, there are significant challenges with integrating external care providers into school settings, or really any new care system. And so, though my work has begun to focus more on schools, I think this is an implementation science-wide problem, or really just a worldwide problem, where when we start to introduce new external providers or interventions, it becomes challenging to really meaningfully and effectively integrate those providers into a different system that they're not fully embedded into. So this is where I'll introduce the YSU, or the Youth Substance Use Unit. So the YSU is an innovative school community partnership that serves adolescents with substance use problems at high schools and newly middle schools on the Eastern Shore of Maryland. And the YSU provides access to a suite of evidence-based practices that include access to a substance use disorder counselor, a peer recovery specialist, virtual access to a buprenorphine treatment prescriber and other psychiatric care prescribers if needed, and also virtual access to a clinical psychologist, which is myself. And the YSU is a mobile treatment unit. So it is a van that our partners at Caroline County Behavioral Health and the Caroline County Health Department on the Eastern Shore actually drive to the local high schools and newly to middle schools and park in the parking lots in sort of a discrete place in the back of the parking lot. And the youth come from class and will join or sort of go onto the van. And then the peer recovery specialist and the substance use disorder counselor are on site. And then you can see in this photo here, this is actually from the room in the back. There is a telehealth enabled room with a camera and a screen here where they can virtually connect to myself as the clinical psychologist, more for youth with co-occurring mental health and behavioral or mental health and substance use challenges. And then they can also telehealth into prescribers at the University of Baltimore Medical School or University of Maryland Medical School in Baltimore. The YSU has been an incredibly exciting project for us to work on. And we know that other similar collaborative school community models are expanding, but we lack evidence on how to make them work effectively or how to implement them more effectively. In general, there's limited guidance for integrating external providers into school systems. I think you hear this a lot in practice, or at least I certainly did as a trained child psychologist. You just hear like working with schools is, quote, really hard. And so we know that there are a lot of challenges in working with school and school-based teams. We don't really have a lot of guidance on how to effectively integrate providers into those settings. And of course, there are real implications of those coordination challenges in the care that we're providing. So if there are breakdowns in coordinating between school and external care providers, that often means missed referrals. We may not miss youth that need our services, or we may struggle to effectively engage youth in our services. And importantly, we know that these are not unique to school-based work. As I mentioned earlier, I think that these challenges and what we could potentially learn from working in school-based and school community partnership models could apply to really any other area or many other areas of implementation science where we're thinking about how to integrate new or external providers into existing care systems. So now I'll talk a little bit about the study one, Rural Maps, which is a community engaged needs assessment. And this is funded by the Center for Addiction Research, Education, and Service Systems, and Service, and it's a science to systems grant program. So this is internal funding to the University of Maryland and the University of Maryland Medical School. It's a joint PI project between Dr. Natalie Spison, who's an addiction medicine physician, and myself. So the practical aims, and I'll differentiate between practical aims and what became our sort of scientific aims or specific aims. The practical aims of this project were really to understand alignment of the existing services that we were providing on the YSU and how those aligned with community needs. The YSU, as I mentioned, is an incredibly exciting and we think innovative partnership, but it often feels like we're building the plane as we fly it. So we had this great idea. We built off an existing adult-focused mobile treatment unit model, and we started serving schools. But now that we're about a year and a half in working in the schools, we're realizing that it may be aligned with our schools and community needs, or it may not. And so we are trying to do a needs assessment to really understand how we're fitting with these local community needs. And then given that we have the flexibility and the potential to expand our services or just to think more efficiently or smartly about how we provide services, really the practical aim of this study is to integrate our substance use services into what we are calling a school-based multi-tiered system of support. So MTSS are very common for folks that are sort of knowledgeable about school-based mental health. And basically, when you think about an MTSS, we think about how do we provide universal prevention. So what is prevention programming that all kids in the school could get related to substance use prevention? How do we provide higher touch, targeted intervention for at-risk groups? And then tier 3, how do we provide intensive intervention for those that have a documented need or a substance use disorder? So what we realized, even just in thinking about the YSU, is that we have resources like a peer recovery specialist who would be happy to provide universal prevention or even targeted intervention. But a lot of our resources and a lot of what we're existing or what we're already doing really has been targeted in tier 3. So how do we start to fill out this MTSS in a little more robust way at all of our levels? So translating that into the specific aims for our grant, one, we aim to conduct a mixed methods needs assessment of adolescent substance use concerns, and then select and align evidence-based intervention. And we're using that broadly to also include prevention strategies across multiple levels of our MTSS. And then 3, plan for the implementation and sustainment of selected intervention strategies. So how do we either plan for continued or new implementation of things we may or may not be providing already on the YSU, and how do we plan for their sustainment? So to conduct the mixed methods needs assessment, our first step was to look at the existing referral data. So what referrals are we getting from the schools? And also look at measurement-based care client reports. So look at the symptom measures of folks who are being treated on the YSU to determine what is the level of need and what are the common problems that we're serving of kids on the YSU. Are we mostly, and I can tell you, we are mostly treating youth that have a high level of cannabis use. We're also about to launch some semi-structured interviews where we'll conduct these interviews with youth their caregivers, and community collaborators across these communities. And the goal for these interviews will be to understand how do social and environmental factors influence motivations, initiation, and maintenance of substance use for rural adolescents. So as I mentioned, we know that there is an increased risk or higher levels of use or specific types of use relative to urban peers in rural communities. So part of what we want to do, really grounding ourselves in the socioecological model, is thinking about what is it about the rural context that seems to influence motivation, initiation, and or maintenance of substance use for these adolescents. And then we'll ground the quantitative and qualitative data together and integrate them using an exploratory sequential mixed methods design, where really we'll kind of take our quantitative data first and then explore a little more qualitatively to understand the patterns and what we're seeing. That'll move us into aims 2 and 3, where we'll first select and align our evidence-based strategies across the MTSS through adolescent and community advisory boards. And then we'll plan for the implementation and sustainment of our selected strategies using really what is an approach informed by implementation mapping. So a systematic process by which we're planning or selecting implementation strategies. So this will hopefully launch in the summer, where we will begin with conducting community advisory board and adolescent advisory board meetings to review the results from our qualitative or mixed method needs assessment, construct logic models of the problem. So can we construct a logic model to understand what may be happening in this community or these communities and the best way to intervene? We'll refine the logic models together, brainstorm potential intervention and prevention approaches, and then review and refine these strategies. And then particularly with our community collaborators, we'll think about how to plan for their implementation. The early findings, and so I'll put the big caveat on it that we're early into this study, but have been working together as a group for longer. And what we see is that our referrals are inconsistent and we're not working at capacity. So we know that there's a tremendous need in this community. I think one of the benefits of working with this community partnership and this local behavioral health department is that because it's in a rural community, everyone knows each other. So my substance use disorder counselor on the ground, her child goes to one of the schools that we work in. They are friends with people at the police department and at the EMS. And so we know both from our connections and also just, the folks that are on the ground, there's a much higher need than the referrals that we're getting. I hear from my patients that I'm serving that their client or their friends are caught with cannabis on their person at school, and yet we're not getting referrals about these kids. And so we know that our referrals are inconsistent. And as a result, we're actually not even working at capacity. So there's this tremendous need, and I have multiple open clinic slots in my schedule every week. And so one of our big challenges in thinking about how do we scale up is how do we ensure that we are actually generating demand for these services and making sure that people are aware that we are there to provide these services. And our thinking being is that there are just unique socioecological factors that impact both the need for and the uptake of this intervention. And one thing that I think has also come out in some of the early work and some of the work that I've seen clinically is just that there are high levels of trauma and also shared intergenerational substance use. And so it's not uncommon to hear about high levels of trauma, but also how substance use is really something that has become an intergenerational pattern. And so one of the evidence-based strategies, of course, to address adolescent substance use is to really lean heavily into parent engagement. But when parents are often using as well, or maybe even, I wouldn't say supportive of use, but not condemning of use, it becomes harder, especially in a school-based model where parents may be at work when you're trying to otherwise engage the youth in care. And so, again, these are kind of all laying the groundwork for, we think that our strategies work, and we're hoping that they'll be aligned with the needs in this community, But really, it's an implementation problem where our biggest challenge continues to be integration and integrating ourselves into this care system or into this school system, which kind of laid the groundwork for this second study, which will be the basis of my K23. This is under review now. So the basis of this is a dynamic approach to integrate and sustain adolescent substance use services in rural schools. So as I mentioned, this has been informed by my own clinical experience on the ground and also my own experiences in implementation science. And the strategies that we think are needed to implement the YSU are constantly changing and may be different at each school that we serve. So the strategies that worked for us to ensure referrals last year or for us to drive demand last year don't seem to be working as effectively this year. And we have one school where our principal is super on board. They are constantly giving us referrals. It seems to be integrated into the discipline plan. When someone is found with cannabis or another substance on their person, it triggers an automatic referral to us. But that is actually not consistent across schools and for some reason may or may not work across both schools. And so our hypothesis, and this is grounded in the dynamic sustainability framework, is that successful integration and maintenance of interventions, such as the YSU, require strategies that are contextually appropriate, so specific to each school and site, feasible and capable of evolving alongside changing school and community environments. And that these often typical implementation science approaches that are typically funded, and there are reasons for this, this is kind of what the NIH likes, tend to be these static or maybe prescriptive or one-size-fits-all implementation approaches that may fail to maintain alignment with changing contexts and priorities of service settings. And so when I was thinking through how to, again, design a research project that I thought was grounded in a pragmatic reality, but also rigorous and potentially fundable, I didn't want to propose a study design where I randomized to one of two implementation strategies and then just randomized them and compared them against each other. And so it became sort of our practical aim is to think about how to better integrate the YSU into 3 different schools that we work with on a daily basis, which could help us improve reach and outcomes for youth with substance use challenges. And then how we translated that into our scientific specific aims was to, of course, the classic implementation science aim 1, identify determinants and opportunities to improve implementation of the YSU. Use that to develop and adapt initial implementation strategies to improve reach and implementation of the YSU into rural schools. And then this is what I think is my favorite part, what I think is the more innovative implementation approach here, is to evaluate the YSU in a type 2 hybrid effectiveness implementation trial using an adaptive iterative design where we will recruit and randomize 60 adolescents across 3 schools. So what this looks like, aim 1, where we look for our opportunities to improve, then we'll use that to develop and adapt our implementation strategies and then conduct a pilot trial, which is grounded by the RE-AIM framework or the Reach Effectiveness Adoption, Implementation, and Maintenance framework, where our main outcomes really are reach. So what proportion of the target population are we reaching with the YSU? How effectively are we implementing our intervention, or how effective is our intervention in this community or in this context? And then implementation, to what extent is the intervention implemented as we hope it is, and is there some potential for maintenance afterwards? So classically, aim 1 to identify determinants and opportunities to improve implementation of the YSU. We'll conduct semi-structured interviews with constituents. I use this word sort of in favor of or instead of stakeholders. So we're thinking about constituents being those who are working in the YSU. So the substance use disorder counselors, the peer recovery specialists, prescribers, and then also our folks, sort of administrative folks on the ground at the local community behavioral health agency. And then also our guidance counselors, school-based mental health providers, and others key school personnel, such as our principals from each school. They'll be invited to participate in semi-structured interviews where they'll be informed by the consolidated framework for implementation research, again, to try to identify what is getting in the way of us really effectively using this service, and what seems to be the determinants of effectively integrating the YSU into these school settings from the perspective of our school-based constituents. We'll use that to develop and adapt initial implementation strategies to improve reach and implementation of the YSU. So all of those same folks will be invited to join implementation working groups. And the IWGs will be separate at each school to allow for site-specific tailoring. And then again, we'll follow this sort of implementation mapping process where the IWGs for each school will meet over the summer and review the findings on the determinants for the YSU implementation and prioritize those determinants of what may be most important to address in order to support implementation. They'll also identify implementation outcomes and create matrices of change. So another one of the things that we're doing in this study is that rather than just saying we want our reach to be high, or we want our intervention to be acceptable or feasible, and looking at that against this sort of reflective measure of acceptability of feasibility, we are prescriptively setting implementation benchmarks. So we'll use our implementation mapping process to say, okay, our goal is that we want high reach. How do we quantify reach? What is an acceptable amount of reach for us? Do we want to have X number of referrals that turns into X percentage of successful uptake in care? And so we are prescriptively identifying what our sort of good implementation benchmarks would be so that we know when are we implementing well enough, because I think that there will probably always be opportunities to improve the acceptability of something or make something a little more feasible just because that's human nature. But there also becomes a point in implementation science where we have to say this is just good enough and now we can focus on something else. After we've identified those benchmarks and our matrices of chains, we'll come together to select and tailor our implementation strategies. So again, if we're thinking about how to ensure that we have 80% of referrals that lead into a successful intake appointment, what are the strategies to both drive referrals and ensure that those kids are showing up on the van 7 days later? And so we'll select and tailor our implementation strategies around those specified implementation benchmarks. And then in the next meeting, produce our implementation protocols and materials. So we'll specify those strategies, determine how they're going to work, problem solve how we'll put them into practice. And then here's, again, just another example. So I keep harping on referrals because I think that was the focus of our last meeting on Tuesday. So our determinant being challenging identifying and referring students. So one example strategy could be providing training and screening and defining a clear referral pathway to school-based staff. And sorry that that's cut off there. So with those defined implementation benchmarks and strategy packages, we'll move into aim 3, which is to evaluate the YSU in a type 2 hybrid effectiveness implementation trial using an adaptive iterative design. We'll look at implementation outcomes, including reach and engagement in care, fidelity to those specified implementation strategies, and also acceptability and feasibility of the YSU implementation as a whole, as well as the specific implementation strategies. And then we'll also look at the effectiveness of the YSU. So we'll look at substance use using both self-report and urinalysis. We'll look at opioid-related knowledge and likelihood to engage in opioid misuse behaviors, again, trying to make the case that early intervention and prevention is also critical for reducing later, higher-risk opioid use disorder. And then we'll also examine motivation for substance use and problems associated with substance use, as well as mental health symptoms, because we know that so many of the people or the youth that are being seen on the YSU are also with co-occurring mental health problems. For effectiveness. So in this study, we're not changing any of the services that are delivered on the YSU. I was not interested in proposing a new intervention or adapting an existing EBI or evidence-based treatment for this new model. So we're just proposing to keep the services delivered as usual, which is because it seems to be working. You know, we have the ability to match services truly to what is needed by our youth. So if our youth needs just substance use counseling and no connection to a prescriber or a clinical psychologist, we're able to provide that. We're able to individualize. And so we wanted to keep our clinical service model the same rather than trialing a new specific intervention. I also think that was more appropriate for, you know, the where we were at in the process of proposing this. Our kids have diverse needs. And so it seemed like the best thing to do clinically was to leave things the same and then still try to generate some baseline effectiveness of what our current package of intervention strategies were able to provide. So we'll look at effectiveness outcomes across baseline and then 30 and 90 days. The effectiveness outcome measurement, I think, was particularly challenging when we think about how to sequence collecting outcomes across the school-based calendar and semesters and things like that. So this was a discussion and kind of what we settled on as a team and with some guidance from more senior school-based mental health researchers. And then on implementation, the procedures for our implementation. So as I mentioned, the YSU staff and our implementation working groups at each school will develop and aim to this package of selected implementation strategies, which will then be used in aim 3. And they will document their use of the selected implementation strategies and any adaptations they may need to make to these strategies throughout each semester. And then at the conclusion of each semester, the implementation working groups from each school will review their implementation data. So they'll review their referrals. They'll review how many kids were able to come back for a predetermined number of sessions. And then they'll review that following a modified implementation facilitation approach. And so what we'll do then is in these semesterly facilitation meetings, as an embedded facilitator, I'll help our teams review the implementation data and then assess the performance of each of our implementation strategies that we've selected against our implementation benchmarks. So for example, we'll determine ideal levels of completed referrals in aim 2 and then examine the number of completed referrals and how well our specified implementation strategy aided us or impeded us potentially in meeting that benchmark of referrals. And then we can choose to either retain that strategy, adapt the strategy, or replace it with something totally different. So to look at this visually, what that means is that in year 1, we'll start in the fall implementing the strategies that are determined from aim 2. We will take a pause over the December break and reflect on how those strategies were serving us, and then come back each semester after that and continue implementing the strategies, reflecting on the data, and then refining or adapting as needed over the course of a 3-year adaptive iterative trial. And so this is the adaptive iterative nature where we're able to iterate on our implementation strategies. We're not fixed on a specific set of strategies, and we can always adapt, repeal, replace. And the whole while we'll never stop providing clinical services. And so that'll be ongoing as well as sort of recruitment on the clinical effectiveness aims. This is a busy table of our reach and implementation outcome measures. So broken down by the re-aim areas. So we'll look at referrals using our treatment records, our engagement and retention and care. And then on implementation, we'll look at fidelity to the selected strategies, adaptations to our selected implementation strategies, and then the feasibility and acceptability of these strategies as well. So those will be sort of our outcome measures by which we'll measure each of the strategies. And of course, all the while we'll be validating them or comparing them against our implementation benchmarks as well. And so just because something may be may have a 4 out of 4 acceptability and a 3.9 out of 4 feasibility, but if it's not serving our implementation benchmarks, if it's not helping us to increase our number of referrals, it would still be eligible to kind of be scrapped at the end of the semester. And then for our effectiveness measures on outcomes, we will look at, or we'll conduct a timeline follow back for self-reported substance use and also conduct a urinalysis. The YSU is already conducting urinalysis. There's already the potential to do urinalysis on the YSU. So this will be just gleaned from routine data collection. We'll also, to assess their knowledge of and likelihood of opioid use, we'll look at the Adolescent Opioid Safety and Learning Scale. We'll look at problems associated with substance use through the short inventory of problems. And then we'll also look at depressive and anxiety symptoms using the PHQ-9 and the GAD-7, respectively. For our analysis on the implementation aims, we'll look descriptively for each site and across each implementation cycle to describe the implementation outcomes first, and then explore changes across cycles and the effect of this adaptive iterative approach using a one-way ANOVA or a Kruskal-Wallis test if it's indicated for non-parametric data. And then across effectiveness, similarly, we'll look descriptively first at participant level changes in symptoms to quantify and describe the effectiveness of the YSU across all of our outcome measures. And then we also will be able to compare changes or change scores across implementation cycles using one-way ANOVAs and visual trend analysis. Implications for dissemination and implementation research. So again, this is kind of reflecting on my experience, both working on the YSU clinically and then also the experience of pulling together the methods on these trials and trying to balance what I think is rigorous and important and impactful innovative research, but also something that's really pragmatic and grounded in the community and not proposing a research question because I find it interesting, but also because I also think that it's going to result in a meaningful improvement of the care that we're providing in our clinical service. Because ultimately, I think that D&I research is most powerful when it's embedded in real care delivery systems and answering questions that arise from real world challenges. And I think that most folks on the call, I think most people in general would agree with this statement. But unfortunately, I've done some work on this and I don't cite it here, but D&I research has historically struggled to meaningfully engage and empower community partners in its implementation research, and has typically over-focused on outcomes like fidelity to investigator-determined EBPs or really championed acceptability and feasibility, and that trickled down to what that means for either clinical effectiveness or things like reach and sustainability, I think is sort of, it's often been watered down. And so I don't cite this here, but just so you know, I'm not just making this up. We actually did a scoping review of D&I research specifically in adolescent or youth and adolescent mental health, EBP implementation projects, and rated each project on their level of partner engagement and how effectively did they actually partner with community partners and empower them. And what we found is that most projects, most D&I projects struggle to effectively partner and empower, particularly their community partners, and typically will look or try to explain after the fact, after giving an implementation directive, what happened and describe implementation challenges. And it's less common to really start from the beginning embedded in an existing clinical partnership and really do the implementation research from within that. And so I think that's one of the strengths of our model is that it's really embedded in what was initially a partner-led innovation. So I didn't provide the whole history of this, but I'm lucky to have just had the opportunity or had the luck to be hired at the same time that this partnership was really kicking off, that they were starting to serve the schools. And so this wasn't something that the University of Maryland came in and said, hey, we think it would be great if we could partner together and start serving these schools. It really was Caroline County Behavioral Health serving these schools, and we were lucky enough to come in at the same time. And I was fortunate enough to say, hey, I would actually love to also be embedded in this unit, and could we find a way to make this work? And so I think that's one of the strengths of this proposal or of this study and these sort of two studies is that they really have always been the key decision makers throughout the process. And so we're trying to maintain that, especially as we move through the research process together. Methodologically, I hope that this approach of iterative adaptation throughout the trial, which others in implementation science have written about, but we hope this will allow us to refine our implementation processes without being constrained by a traditional randomized design where we're randomized to either one or two implementation strategies. And it allows us to flexibly apply implementation methods like implementation facilitation, adaptation tracking using something like the modified frame, IS, and implementation mapping. All of these other implementation methods that we can use to kind of infuse rigor into this approach that really also grants us a high degree of flexibility. And another important methodological advancement, I think, is by allowing us to engage in this iterative adaptive approach, we're also relying on the use of clear implementation benchmarks to guide our adaptations. So we're moving away from more general measures of constructs, which in my experience, I think have often been impacted by ceiling effects. And this challenge of like, what really does 3.5 on the implementation or the acceptability of implementation measure or the aim or the FIM, what does that really mean? And so by grounding or sort of pairing these reflective measures of implementation constructs with these clear implementation benchmarks, we're also able to move towards a more pragmatic approach that also blends these two implementation measurement approaches. Okay, so I'll say thanks to you all for attending. I am hoping that there'll be some questions in the chat, and we have a fair bit of time to facilitate some questions. So thanks all for your attention.
Thank you so much, Dr. Triplett. Your emphasis and commitment to the community partnerships is really inspiring, and I can't wait to read more about your findings and learn more from you as your study progresses.
Thank you.
We do have some questions. I'm actually going to start things off with one question. When you were mentioning the implementation mapping process and prioritization of determinants, could you share a little bit more about your method for determinant prioritization, how you went about that?
Yeah, and so the determinant prioritization, it has not yet happened. So that'll happen over the summer, I believe, depending on which phase we're talking about. But our plan as of now, and so it can always change, but our plan as of now is to do a mix of just discussing as a group what do we think are our priorities or what do we think are the major priorities here, but also to do sort of a after the fact data collection, like a prioritization of form, just a short Google form, and then bring that back to the group as well to say, this seems to be the consensus from the discussion, but then also here are some of the things that, quantitatively when we look at this is how people tended to rank them. So how do we, balance both of those? It's interesting. I think there are ways to really like infuse a lot of rigor into the determinant prioritization process to the point where like that becomes a study in its own. But then again, we're also working with these constraints of like, we really just have like 4 meetings to plan what we're going to do. And so how do you do it just like good enough, which I think is a necessary for working in community, but can also be like a process of restraint, I think, as an investigator.
Yeah, I agree. Thanks for clarifying that.
Mm.
So another question we have is about the methods you use to track fidelity to implementation strategies in terms of the log. Could you describe a little bit more what the log looked like, or it was, anything you could share more about that form or how you went about that?
Yeah, and I don't think I have an extra slide that provides a visual, but adaptation tracking is based off of the Frame IS. So it's a specific, like, I can't remember what Frame stands for, but it's an adaptation tracking tool that was developed. I think the first author is Shannon Wiltsey-Sturman. She's definitely an author on those papers. And so it's a modified adaptation tracking tracking tool specifically to look at tracking adaptations to implementation strategies. And so we took the Frame as our base. And then what we'll do is, alongside with the folks on the ground, kind of water it down a bit so that it's something that they can do on the fly or faster. With the thinking being that we want to collect the data, but we'll also, since we are meeting regularly for facilitation meetings, and we also, as a group, have like a standing weekly meeting for clinical supervision, we can always sort of, fill out in greater detail the adaptation tracking measures. So it's sort of like a really high level version of the Frame implementation strategy tool that we can always fill out and adapt a little more in conversation with the community partners. Again, just trying to minimize the burden placed on them to do all of these things and also implement strategies and also track their adaptation to strategies. So.
Thank you. Yeah, it's always a balance. Fidelity measurement can be very burdensome for those who need to report on it and keep track.
Yes, exactly.
So we have another question that relates, well, I mean, it's a compliment too. What happens if you become too successful with facilitating referrals? And have you thought about how you might have to scale and sustain the service or the scalability of this intervention?
Yes. So we have thought about that, perhaps too much about it. So like on the logistical side of things, I think my hope for scaling and sustaining this service in this community specifically, but also in scaling potentially to working with other communities and other schools across Maryland, is to embed this in the training programs that we have at the University of Maryland. So we have a clinical psychology PhD program that I have an affiliation with. And so I think there would be the opportunity with enough clinical need to bring in an extern student from our clinical PhD program. But then also our medical school has a robust child and actually school behavioral health specific internship program that we could recruit interns from, and then our child and adolescent psychiatry fellows. And so I think our next step in thinking about scaling and sustaining this is to think about how we can bring in more trainees potentially to address clinical need. But the sort of on the ground implementation, like one of the real barriers, I think, to actually scaling and sustaining this is the model of providing services from the van is great and it is very private, and I think people appreciate that. But it also means that we are just limited in how many people we can see a day because we don't stack our clients in the van. So if I'm seeing someone on telehealth in the back, that means that our substance use counselor who sits in the front isn't going to take another client at the same time because we don't want them to hear each other's sessions. And so one of my ideas, and also thinking about even just how to expand a model like this to other schools, is to also, with better integration in the schools, think about how to expand to still providing telehealth services, but maybe somewhere in the school, or maybe, some other location on school grounds that would enable us to see multiple people at once, but still rely on this like external partnership model.
Thank you. That makes a lot of sense, and glad to hear you're already thinking about it a lot. Another attendee said you mentioned low parent engagement partly because these are school-based interventions, and we find similar issues with our school-based health clinics. How do you manage parent consent for treatment given the low caregiver engagement? And actually, it's an interesting point as well because, with the intergenerational point you made about substance use, if you have thought about caregiver focused, components too, would be my follow-up to that.
Yeah. Yeah. So our team on the ground is really great about managing consent. And I think, again, that's one of we often talk about the challenges of rural work, but I think that's also one of the pros or, facilitators of rural work is that our team on the ground, everyone knows everyone in this community. And so we don't really have that many challenges with getting consent. Or if we do, they don't come up to me. And this is where I get to like, again, I'm like a little lucky in that, like, if they're coming to me, someone else has already consented them. And so I'm sure there are more challenges than I'm letting on to, but I think that the challenge has not so much for us been consent as much as it has just been maintaining engagement. We're able to get parents to consent, but they, for one reason or another, we're providing services during the hours of like 10 a.m. and 1 p.m. So they're at work. They can't call into a session. And it's hard for our providers and myself who are working all day to then wait until a parent gets offline or finishes their job and then call at 6 p.m. to update the parent. And so I think it's just an ongoing challenge that we haven't necessarily like identified the best strategy for, especially not a strategy that really takes care of our workforce. Because I think the workaround has been to wait until parents are, done working the day or find when parents are available for a talk. But I also recognize that like providers are burnt out. And so I'm not going to say to my substance use counselors on the ground, like, oh, I can't make this call at 5, or I don't know the parents. So can you give them a call? I know it'll be after your workday. And so I'm very invested in making sure we're taking care of everyone. But to address the follow-up, I think one thing that I am really interested in, and that pairs really nicely with a lot of other work that we've done in this community on our adult treatment side, is to think about the role of our peer recovery specialists, and whether that be the peer that's already on the van or another peer recovery specialist that we can hire and employ. And if we were to start kind of doing a more clinical intervention type trial, I think there's a major role for peer recovery specialists to help support parent engagement in adolescent treatment. And so on one of our other studies that we do in the Center for Substance Use Addiction and Health Research, we have a peer recovery specialist that provides peer recovery support to individuals that are on medication for opioid use disorder. And actually, I provide the clinical supervision to her as sort of she has a peer supervisor, and then I'm a backup just in case any clinical emergencies come up or she wants someone to think through on that side of things. But she is a parent herself. And actually, I think her and I have had really good conversations about, how it can feel as a parent and also as a peer recovery specialist, and wanting to be able to provide that peer support to parents who may also be in recovery or have a history of substance use and are now realizing that their kids are at this increased risk of developing substance use disorder, or their kids are starting to engage in higher risk use. And so that is sort of one of my ideal or hopeful next research paths that I think addresses the engagement barrier, but also becomes, I think, a powerful opportunity for community and just driving connection between peers who are already providing some support and are already sort of this established behavioral health workforce that can now be used in this way to support parents engaging in their youth or their children's care.
No, that's great. Great. Okay, we have another comment and question. It is such a good point that we must balance rigor with practicality. Could you speak a bit to how you navigate this balance? What factors are you thinking about as you make decisions?
So I don't know that I balance it best, because I think I probably often lean more towards the practicality side of things than the rigor. And so I guess when I'm making these decisions or I'm thinking about these things, and it's a little different too, because I'm already embedded in the clinical service and I just meet with the other providers so often. And so they're always front of mind for me. And so I'm always leaning towards like, how can I make our lives a little easier? And then I think when the rigor comes in is when I like get more excited, or just thinking like, okay, if I already want to do this, then how can I just be creative and like choosing something that kind of complements what I already think that we should be doing or already want to do. And so in the idea to take this adaptive iterative design in the trial really came from like, I had already decided I want us to have flexibility to change what we're going to do and like not feel locked down to one specific approach. And now I just need to like do a bit of intentional lit searching to find a method that's going to let me be able to do this. And so I think I start with the practical consideration and then try to identify ways to bring rigor in. Um, but it is like it always feels like a give and take.
Yep, agreed. Okay, we probably have time for one, maybe two more questions. Another question relates to your selection of implementation frameworks. How did you select the particular frameworks that you used?
Good question. I would say mostly familiarity, to be 100% transparent and honest. My mentors on this study particularly had experience using re-aim. And so I was more familiar with that and more familiar with CIFR. So that probably led the selection. But then just in looking at it, I like re-aim because it again focus our big challenge was always reach. And so it just felt like such a natural choice to have something that really led with reach. Um, and then for CIFR, I particularly like the CIFR because as someone that has this sort of global public health training, so I was a global health major in undergrad, I've always thought about, and also as a child psychologist, you always kind of think about the environmental effects on behavior. And I mean, we can think about it in terms of behavioral health problems, but also just human behavior in general. We're influenced by things at multiple levels. And so I like the CIFR because it really specifically the domains of the CIFR allow me to say like there are things that are going on in the outer system that are just happening in the rural community that impact the implementation of my services. And so I think that really was what led me to choose that. But I think there are so many implementation frameworks that I kind of just allowed myself to lead with like, okay, I think that each one has its own pros and cons. But I was more familiar with those and they kind of worked well enough. So I just allowed myself to lead with familiarity.
That's great. I think it's a question a lot of us grapple with, but it also sounds like some of the constructs aligned with what you thought was
Yeah.
most important for your
Yeah.
studies. So great. Okay, well, we're almost at the top of the hour, so I think I'll wrap things up. Thank you everyone for attending today, and a big thanks to Dr. Triplett for presenting. As a reminder, next Tuesday, November 11th at 12 p.m., we will have Dr. Sophia Bartels presenting on optimizing the development and tracking of implementation and sustainment strategies, lessons learned from two large-scale implementation science studies. So thanks again for everyone who attended today and hope to see you next week. Take care.